Good afternoon, everyone. My name is Duncan Ross, and I'm going to be talking to you about exosomes today. What you're looking at here is a mitochondria. And what I love about this image is that we have antibodies on the surface of that mitochondria, but this is a new type of microscopy called D-storm microscopy. And the issue with exosomes is that they are so small that without this type of microscopy, we can't see them. But I personally, as a scientist, love this image. So again, my name is Duncan Ross. I am the founder of Chimera Labs. And if you're interested in exosomes, our website is exosomes.com afterwards. This is where I come from in Miami, and I'm very glad to be invited to your first conference. I am positive that we will be working together in the future after you see this data. But I have set up my first exosome conference in Miami in a few days. So this is in 2014. So this is a friend of mine with a topical second-degree burn. And simply by applying exosomes from mesenchymal stem cells, placental mesenchymal stem cells, we've got this kind of resolution in 7 days. This is actually 20 days later, but in 7 days, there was no more injury, which is what you would expect from a mesenchymal stem cell if you could apply cells in that fashion. However, that's not possible. What's beautiful about exosomes is that they can be frozen, not cryopreserved, just frozen, and taken off the shelf out of the freezer and applied in a daily fashion. And what we're doing really is we're stopping the inflammation at the beginning of this process and allowing normal non-fibrotic proliferation over the next few days. So what I find so interesting about this is I read this paper a long time ago, and I found it so interesting because as many people in this room, I started with stromal vascular fraction from adipose. Then I started culturing the cells to have more mesenchymal stem cells. And it's from that culturing that I got into exosomes. But when I was working on cells alone, this idea that you could move cells around with ferrous labeled exosome cell was very interesting to me. And this is used in multiple sclerosis, so you could specifically target the lesion. So coming here is kind of bringing that idea back around, and you could imagine a superparaganglionic iron labeled exosomes in the future, and hopefully we can get there. So what we're looking at is these very tiny exosomes that are being taken up by a cell here. And this is using that same microscopy here. So they're very small and taken up very quickly. If you think about what their distribution would be with a cell, normally the cells are caught in the lungs. We know this. Why? Because the lungs are like bone marrow. They are in an area where bone is made. So that's why they think they want to go there. But if you look at MSCs in a normal mouse, you will get MSC exosomes in the spleen and liver. They're able to traffic through the lung. If you have an injury, say in a kidney, they will also traffic to the kidney. And I'll get to why in a second. Because as we're interested in distribution of particles here, I started with this experiment. This is our exosomes. This is one of the pieces of data we're using for our FDA application. And we labeled our exosomes with a membrane dye and see where they went. So at 0 hours, we see to 4 hours, the exosomes are given IV, and you can see they traffic to the spleen. But they also traffic to the brain. So now, if you look in the next image, I got kind of lucky here because these 3 mice are correct. IV administration, they're then taken up in the spleen. But this one was a mistake. In this one, the operator did not get the exosomes into the IV, they got them subcutaneous. And you see that they remain there, but they also traffic because they're so small. They go directly in the lymph, they're taken down, and you can even see, though, that there are some exosomes in the brain. So if you have a tool to work with the dissemination of those exosomes, push those surface exosomes farther in, or anything to that effect, that's very exciting for me. And just to prove that I've been thinking about this for a long time, I own two of these piezo waves. I own a shock wave. I had heard that there was a machine like this out here, but I had never seen one. The issue with this is if you're going to treat a tendinitis or plantar fasciitis, for instance, I require that you use some kind of shockwave therapy prior to using my exosomes because I don't like failure. I mean, I have to have positive patient outcomes. The issue with this is you'd have to do this 5 days prior to the administration of my exosomes. So, which makes me very questioning what the convolution of these multiple uses are going to be. We also talked earlier about ultrasound, therapeutic ultrasound. I have been working with this clinical professor from the University of California to try to demonstrate that by targeting focused ultrasound to specific parts of the brain, we can cause an increase in the blood-brain barrier opening and the exosomes crossing it. And I've done these rat models using their machine at the City of Hope, and we have demonstrated that indeed we do open the blood-brain barrier with this, and the exosomes proliferate past. In this case, we're trying to target a cerebral palsy child and target those exosomes directly, and this is one of those types of things. But you can see that when you do target that energy there, you do get an increase. So I've been thinking about this for a long time, and it's nice to see that there's new methods. So how did I come across this idea of an exosome versus a cell? I had been culturing the 70-year-old wife of my plastic surgeon. I had also been culturing an 18-year-old paraplegic. You can see that her cells grew very easily, and I could not get her cells to grow. So I was at the point, you see how they're all flat like that? I was at the point where I was about to give up and throw them out. But so I thought, well, listen, I know that there's growth factors in here. Maybe if I take them from here to here, maybe these will start to grow. And in fact, I could see these dendrites start to move out to each other because I was looking at it so carefully. So that was kind of the aha moment that I don't need the cells, I need the growth factors. But I have a PhD in biochemistry as well as immunology. Proteins are too labile. They're not going to persist. Messenger RNA, siRNA failed in the clinic many years ago because it also doesn't persist. What is happening is that there is a lipid bilayer being secreted that is protecting those cells. So that became very exciting. And then I started to think, well, why did the older cells not work? Why did I have so many patients that failed? You showed me a patient with a wound, a diabetic ulcer that wasn't working with autologous therapy. And that is why, because he was an older gentleman and really didn't have the secretion of the protein content and exosome and microRNA content that he would need. And so if you look at these two papers, this is a 40-year-old and this is embryonic. This one has, they can verify 300 cells being secreted from the MSC. And in this one, from the 40-year-old, there are only 100. And from the younger one, there were 300. So that sort of led me down this path, and I have my background is in bone marrow transplantation. I know that allogeneic cells are going to be rejected, as my father had leukemia, and that's why I started with my PhD. So the youngest ethical cells I can get now, at least in the United States, I don't know about Europe, are placental. And if an exosome is this size, and a bacteria is the same size as a cell, this is something that would haunt me. If I got a patient's cells contaminated, I was finished, right? But if you can filter out those larger cells and only get a sterile prep of exosomes, I have never had a contaminated product since I started in 2014 for that reason. If you're working in a GMP environment, it's very hard. So what we're doing is think about the placenta as the olive tree. We're growing the olives, and then I'm actually isolating the olive oil and then testing it in quarantine and releasing it. So I have 45 employees. We have a 3,000 meter squared laboratory, 27,000 square feet. And now we're taking that data from our FDA application and giving it to the EMA. So I very seriously wish that these types of plantar fasciitis, these tendinitis, these tissue therapeutics will be legal as soon as I start getting that. Now, again, I'm just starting to work in Europe. I'm I have places in Germany, et cetera, but I don't understand the regulatory environment here very well yet. So this is our inspection by the FDA a few years ago. This is our third clean room right there. And lots of our happy people, that's our second clean room. That's our wet labs. This man is the head of the FDA of CBER. And the issue with exosomes is there's so much confusion as to what an exosome is, because it's very easy to tell someone you have an exosome if you have a particle, but to have a real exosome is a lot more difficult than that. And in fact, if there's exosomes in milk, cow exosomes, are those regulated? No, we drink milk every day. So it's been very difficult. And this MD PhD, Jennifer Jones from the NIH, says that they tested 16 different solutions, one solution with 16 labs, and got 16 different responses for how many exosomes were there, or what kinds of exosomes were there. So this is the way we should do it in the old days, right? This is actually from the University of Ulm. And here you can see our collaborators, University of Ulm, Marion Schneider, who's very lovely woman. You can see that you have particles here. These are exosomes. These are not. So if you count particles alone, you're going to be incorrect as to what kind of product you have. And it's a very scary thing, because this product, when people start working on exosomes, they say, oh, those little particles are exosomes, but they're certainly not. If you have an exosome, you should have a very tight peak at 120 nanometers. And that's what that machine is good for. But I hope this plays. It doesn't play. That's the problem with Macs. But this is tap water right here. There's no exosomes in this solution, but you do see particles, and that's what's the scary issue of the products that are going to start coming. If it was your first time using that machine, you would think that those are exosomes. But we've done these types of things, which is cell exosome uptake over 1 to 4 hours. You can see at 1 hour, the cells are already being taken up. And you saw that in the mouse studies that I showed you before. So this is the way you should be doing it now. This is the same microscope that I showed you first. And this is the exosome. It's the size of COVID. So what makes this so much more difficult is you just can't see it. So this preparation we can do in about 8 hours. We can see the surface markers, CD81, CD63. Sometimes you'll see CD9, depending on the exosome prep you're doing. And now that's just the surface markers, but at least it's much better than just looking at particles. You can see here CD9, that's beneficial. That shows a younger exosome. So what we have is, now we know that we have an exosome, but what's more important is the cargo of that exosome. Here we have microRNA from different lots, and you can see a lot of them were spoken about today, or will be. microRNA 21 and 100 repeated over and over again. If you look up that microRNA 100, you'll find a great amount of data on it. And interestingly, the exosomes are a lot more about microRNA. They're very small RNAs, and the world is starting to come to understand that now. This is a characterization of our exosome versus other claimed exosomes. And you can see that there's no RNA in those. Now, they're confused because they have particles, they have protein, but if you have no nucleic acids, you don't have an effective product. It's like having a Moderna or a Pfizer liposome with no RNA in it. What would be the good of that? So that's something you should look out for in the future. Because of that, we've devised this formula where we take the RNA concentration, we take the protein concentration by high performance liquid chromatography of the exosome section. We put that over total protein concentration, we multiply it times the volume, and we multiply it times a factor of an in vitro test to show anti-inflammation. Other interesting things is there are actually TNAs in there, as well as microRNAs, pieces of those. And if you think, what does a baby do? A baby grows, a baby is anti-inflammatory, and a baby doesn't get cancer. So in many types of cancers, not breast, but say a colorectal cancer, pancreatic, there are losses of microRNAs that can be demonstrated. In this paper, there's a loss of 12 microRNAs. 7 of those microRNAs are in the exosomes. Why? Because a baby has normal functioning. And if you see this microRNA 100 I was talking about there, it's shown to stop emphysema, or COPD, EPOC in Spanish, in laboratory models. We also, when trying to demonstrate our anti-inflammatory outcomes, we look at NF-kappa B, we look at IRAC, we look at to see if we're stopping these pathways to see if we have an effective product. So if you look here, the exosomes are blocking IRAC1 expression, as well as just one microRNA on its own. This is a typical kind of a thing, TNF-alpha expression with LPS in vivo, so we can see the anti-inflammatory products of it. And we've tested many other things, NF-kappa B. This is the tumor information. I can't spend too much time on it. I don't have that time, but it's something to think about in the future. We work now with microneedling, We work with different types of gels, hydrogels, PRFM, PRP. It is good to encapsulate the exosomes to keep them from moving around. And now let me get you to some therapeutic clinical pretty pictures. So we're working quite a bit on hair restoration. We do quite well with that. This is 7 days. Her dog bit her 20 days before her wedding. And that's how we had her 7 days later. That's by a doctor named Chernoff in Miami. This is an interesting outcome. We've been able to stop keloids for 3 years going out on more than 200 patients. Why? Because we're replacing what they're not doing right, just like a baby. Here's another example of that. That is a horse, and you'll see this wound. This is 30 days, and you can watch that wound resolve by topical application, which is pretty amazing. And now this is human exosomes. Why isn't there any kind of rejection? Because you don't have MHC class 1 on the surface of the exosome. It's too small, and so therefore it's not immunogenic, which is a benefit over cells, which I was always worried about. So when I started to think of all this in 2014, I got very excited about what the future possibilities can be. But we use it quite a bit in aesthetics. Another reason I'm excited about Europe is because I feel like there may be less regulation for its use in like I said, tissue therapies. So we're doing quite a bit of aesthetic use over in the United States. We have a COVID application into the FDA. And we're having alopecia areata is being caused by all these patients with COVID and long COVID. And we see that can resolve in as quickly as 30 days. It's very striking how quick that can happen. But again, that's an inflammation-based problem. And where is inflammation? It's in the lymph nodes. These exosomes, when put into the head, they traffic to the lymph nodes. So keep that in mind when thinking about targeting or pushing products. You want to push it to the lymph nodes in the case of inflammation. So we're just about done here, but you can see these later on if you want. That's the exosome conference we're doing, and thank you very much.